Welcome, everyone, to our beautiful city of Halifax. We are on the unceded, unsurrendered territory of the Mi'kmaq people. My name is Monique Fong Hao, and it's so good to see so many familiar faces in the audience. It's been a while since I've been at an HIV gathering of any sort, so I'm very honored to be here, and Mama asked me to do the prayer. My spirit name is White Eagle Dancer, and that was given to me by an elder here in Mi'kmaq. And I am a grandmother of 5 children and raising 3 of them, and a mother of 7. So I have very big family ties. So I'd like everybody to stand if you can. Remove your hats, and I'll do the prayer. Creator, we thank you for this beautiful day. I thank you for allowing me to be here with all these beautiful people who are advocates for our people who are living with HIV and AIDS, STBBIs and Hep C. Creator, I ask that you wrap your loving arms around each and every one of them and thank them for their work. Creator, I also ask that you wrap your loving arms around all those who are in need of your love and guidance, who are living on the street, who are incarcerated, who are living in foster care. Please let them know that we love them, their families love them, and we miss them, and we want them home. And Creator, I want you to welcome all these people here to our beautiful land of Mi'kmaq and let them have a beautiful stay this week. And thank you, everybody, and Miigwech, hi, and Walalin. Thank you.
Good afternoon. My name is Jolie Sasakamoose, and I am honored to have been asked to moderate this important panel discussion here at CAHR 2025. As we gather today in the Mi'kmaq unceded territory and ancestral territory of the Mi'kmaq people, I want to begin by honoring this land and its caretakers and by grounding myself and where I come from and thanking Monique for that good smudge. And when I prayed this morning, I asked that everything I say today be for the greatest good of myself and those around me. So if I make an error, I know that that was a planned error. I live and work in Treaty 4 and 6 territory, and I'm from Chiging First Nation on Manitoba Island, and I come with the voices of my ancestors behind me, and I carry the voices of our people still fighting for our lives on the prairies. I would also like to thank the CAHR board members for organizing this very timely session. We are not here today to merely talk about numbers. We are here to talk about systems that are failing Indigenous people. In Saskatchewan, where I live, the rate of new HIV infections is nearly triple the national average. That's what the data says. I disagree. I think it's much higher. We have some of the highest rates of congenital syphilis in the country. For 5 years, we had 15 cases, and now we have increased over 1,200% in congenital syphilis. We have people are dying of hepatitis C, even though it's treatable. And children are being born into systems that treat their families as disposable. And what's worse is we act like it's normal, but it's not normal. It's not inevitable, and it is unacceptable. These crises are not disconnected. This is syndemic. And syndemics don't happen because of an individual's experience. They happen when racism, poverty, colonization, and grief stack up like firewood, and someone has struck a match. In Saskatchewan, that fire is burning, and Indigenous people are the ones inhaling the smoke, while the governments argue over whose responsibility it is. This is a spiritual crisis, it's a justice crisis, and it's a policy crisis. And every statistic has a name, a face, a family, a father, a son, a husband, a community. Let me say this with hope and optimism. Indigenous communities are not broken. Indigenous peoples are not waiting to be saved. They are saving each other with ceremony, with love, and with programs that are built for Indigenous people by Indigenous people. Nothing about us without us. at Sunshine House, at Sanctum, at Gunnigunnicut, Indigenous peoples are building care models grounded with dignity and care and culture. They are doing it underfunded, understaffed, and often unrecognized, but they're doing it anyway. So today, we are not here to admire the problem. We are here to name the systems, amplify what's working, and demand action worthy of people we serve. We have brought together a powerful panel of experts and community leaders who are working tirelessly to address these syndemics in the prairies. And I would like to start out by introducing Albert McLeod. Okay.
Thank you for the opening, and thank you, Monique Fong. Monique's aunt worked in the first days of HIV and AIDS in Canada. She was in Saskatchewan. She was the elder for the Canadian Aboriginal AIDS Network in the early years. And we had a conference here in Halifax in 1995, which is 30 years ago. And she spoke about losing her son to AIDS, a young man who was a two-spirit man. And she brought him home at the end, and he died at home. And she shared that experience in these rooms. It was at the Sheraton Hotel. But 30 years on, we are back in Halifax speaking about Indigenous people and HIV. And I think we can include AIDS in that title or that theme, because not all Indigenous people are accessing antiretrovirals today in Canada. And we'll progress to what we know as AIDS, called AIDS. So my work has been over 35 years working in the area of HIV and AIDS, beginning in Vancouver in 1980 at the outset of the AIDS pandemic in North America. And for the first 20 years, two-spirit people or Indigenous, gay, and lesbian, particularly men who were homosexual, dealt with that reality of AIDS. Many times we lost our friends who were diagnosed with opportunistic infections. There was a lot of fear and stigma from home communities, so they didn't go home. They died in Vancouver, Edmonton, Winnipeg, Montreal, Toronto, and never returned home. Until the advent of antiretrovirals, it began to change our realities. So I want to share intervention that the Two-Spirit community took back in 1988. And here we have the slide. It was during the Reagan years when the President of the United States would not even bring himself to even say the word AIDS because of the stigma and the association with homosexuality. And the government of the US, I think, perhaps grudgingly agreed to have a gathering in Minneapolis of Indigenous, gay, and lesbian people to look at that community and see what they could do. And a group of people from Winnipeg, 11 of us, heard about this, and we drove down there in the summer of 1988. And we began to share our experiences of dealing with the AIDS pandemic, about ideas about our history, our culture as Indigenous peoples in the Americas, North America particularly. And then we decided then in Minneapolis that we would continue to do this work. So we've been doing it continuously for 37 years. That is an intervention in a syndemic situation, right? I call it Amazing Race Two-Spirit, because you have to find these places in North America. In the early days, we go by bus, Greyhound bus, bicycle, beater car, airplane, train. We would find these places. And that's what we're presenting today about the intervention. It is about reconciliation and decolonization and making safe spaces for Indigenous people who are dealing with anti-Indigenous racism in the healthcare system, homophobia, transphobia, and making spaces where they can pick up these threads that their ancestors left them for the time after colonialism. We are at this time. When Flora Mike spoke that afternoon at the hotel here, near here, she had white hair, she was wearing a white outfit, and she was carrying a white eagle feather. And I swear, in that room when she was speaking, she was shining, she was shimmering, right? Because she brought that spirit of healing with her on the loss of her son. And that is what she was sharing with us. So here you can see we've traveled Long Island, New York, Gambier Island, Horseshoe Bay outside of Vancouver, Tucson, Arizona, San Francisco. We've traveled this continent in our journey dealing with HIV and AIDS as an intervention. So that's what I present here, is this model. In 2018, we wanted to host the gathering in Manitoba. It would have been our third time. And so we usually send a letter to our funders, some of whom you work with, that you are familiar with. One of them replied and said no. It was for $10,000. Not a lot of money. So I was upset, and I wrote a letter to the Prime Minister of Canada, who was Justin Trudeau at the time. And the letter said, over the last 150 years of colonization of Indigenous peoples, it was primarily the Liberal government that suppressed Two-Spirit people. Now, when we want to practice our health, our way of life, introduce knowledge, language, traditions, ceremonies, spirituality, meeting with elders as a way that we come out of these pandemics, your government says no. Within 3 days, we asked for $10,000. Within 3 days, I got a phone call and we got $20,000. That's part of this work, is advocacy and activism. And I know in the past it has become a dirty word in research and in science to be an advocate or to be an activist. But I think it's required now, especially in the prairies. What I have been promoting in terms of a response is a national inquiry why Indigenous people in the prairies are overrepresented in HIV epidemiology, the statistics. Because as Jolie says, they are not normal in the 21st century, in 2025, in a first world country, that Indigenous people would be carrying the burden of HIV and AIDS. And particularly Indigenous women in this country are carrying that burden. You know, we went through the Tainted Blood Inquiry in 1993, and that is where government bought blood from prisoners in the US that had HIV in it for hemophiliacs. That was government policy. That was science of the day. 7,000 hemophiliacs died during that period. Right? There was a national inquiry that went from province to hear what each health department had done with that blood. In Manitoba, one of the government staff told me afterwards, they sent out a notice to 250,000 households in Manitoba, letting them know that if they had any blood transfer in surgery, etc., that they should get tested for hepatitis C. Right? That's where we are today, on the verge of an inquiry. Because you could have good intentions, you could have all the science you want about safe consumption sites, etc., but where is the responsibility of healthcare systems to invest in the interventions that are required to stop the transmission of HIV, to provide proper care to those people? Many are street involved, some are injection drug users, some are homeless. Is the intention that we forcefully assimilate them into Western culture, Western ways of being? Is that our intention for good health in this country? So for myself, I'll be 70 years old. This year, I survived the pandemic, beginning in 1980 at the very outset. And I'm 39 years sober in April. I was 39 years sober. I'm not bragging about that, but I want you to know, in those days, in the 80s, mid-80s, gay men were choosing sobriety as an intervention for HIV transmission. I come from an alcoholic background, substance use background. That was my choice in how to survive that pandemic. For me, it worked. I believe in harm reduction, but for me, that worked for me, and that's why I'm up here today talking to you about this 45-year history that I've experienced in this country. So one of the ways, Ruth Cuthand is a beading artist from Saskatchewan, and she set out to bead the viruses and bacteria that were brought during the trade era of colonization. Smallpox, diphtheria, scarlet fever, TB, the flu. She beaded them to educate Indigenous people. This is our history. This was what happened to us. This is what we survived, these bacteria and viruses. We survived. She made a second series, HIV, COVID-19, hepatitis C, right? That is how we are coming out of these syndemics. Through traditional knowledge, sharing of knowledge, traveling to visit our relatives who have knowledge to share with us, through ceremony. And it just doesn't happen in these conference rooms or in laboratories. In Manitoba, we work with HIV researchers, and we invite them to our sun dances, to our ceremonies, to our pipe ceremonies, to get out of the box, to get away from your desk, from your computer, from your lab, and come into the Indigenous world and learn how we do things, how we promote health, how we heal people, right? So last year, a well-known HIV researcher in Canada was invited to a Two-Spirit Sundance, and he went. And I said, "What did they ask you to do?" He said, "They asked me to chop wood." So think about that as scientists, as PhDs, where you fit into the Indigenous reality, into the Indigenous world, where you begin the conversation, the relationship, the engagement. It may require you to start at chopping wood, right? So I want you to remember this map. The 38th Annual International Gathering will be happening in Canada this year. And there are concerns about what is happening in the US, the violence against research, the violence against transgender people, LGBT people, and Indigenous peoples. But we have to remember syndemics are a perfect storm of colonialism. It is a perfect storm. It is intentional. It's driven by governments that don't have eyes, don't have brains, and will continue what the previous government has done for generation after generation on these lands. Right? So when you think about solutions to a syndemic, let's talk about genocide. You know, democracies can commit genocide. We know from World War II, we have a lot of evidence what Germany did. So Canada is not immune to committing genocide, particularly against Indigenous people, because there's a lot at stake. There's a lot of resource extraction that still has to happen in North America. And there are a lot of people who still want to be millionaires and billionaires. Thank you.
I just want to thank Albert for his remarks this morning. And before I introduce the next speaker, I just want to define the core issues here and to really bring home why this discussion matters. The syndemic crisis in the prairies is not just a biomedical issue. These issues are deeply tied to systemic inequalities, social determinants of health, and the ongoing overdose crises. The Prairie provinces have some of the highest rates, as you've already heard, of new HIV diagnoses in Canada, disproportionately affecting Indigenous communities, people who use drugs, and those facing housing and healthcare crises. Saskatchewan continues to have the highest rates, which is so strange because we have such a small population, and we need actionable solutions. So our next presenter is from CAHR and Dr. Sharu Kaushik, and she will explain the perspective of CAHR's national research strategy, equity-driven funding, and their commitment to community and Indigenous-led research.
Thanks very much, and I'm humbled and honored to be asked to represent CIHR here at this forum. And thank you, Elder MacLeod, for setting the historical perspective, to this very important issue. CIHR is glad to be able to participate. I'm here in a listening mode to understand the situation, and by no means, have we done enough work. So we are here basically to listen to what are the needs and where we need to go with this. I do want to set a little bit of background in terms of the Government of Canada's approach to STBBI initiative. I think most people here know that there's a $21 million investment in STBBI HIV research initiative, which has been there for more than 25 years now. But in terms of the commitment to the Indigenous research that has been there for a long time, and that's a stream that has dedicated funding from that funding. So I just want to flag that since 2018, Canada has endorsed the WHO's global strategies to eliminate HIV, hepatitis, and other STBBI as public threats by 2030. In 2019, in Vancouver at the STBBI conference, Minister Petipa Taylor actually inaugurated the STBBI National Action Plan to follow that through. And all the federal agencies are involved in putting together a coordinated response to address these diseases and issues that are there. The Public Health Agency of Canada is the lead agency that is involved in the public response, and it consolidates provincial and territorial surveillance data that enhances our understanding through programs like TRACS and STBBI field surveillance system, which collects vital public population-specific information. So as has been already indicated, that there have been through multiple speakers here, that even though there is a strategy, it's not going very great because the cases of HIV are actually increasing. Some of that is due to the lack of service access during the COVID pandemic, but we know that in 2023, there were 2,400 new cases of HIV, a 35% increase from 2022. And while nationally the numbers are, around 6 per 100,000 people, as was mentioned earlier, in Manitoba and Saskatchewan, those are more than double, 19 to 20 cases per 100,000. And these are, as was again mentioned, not just because of COVID or, other intersecting factors. It has to do with structural inequalities, especially among the Indigenous communities who are facing a number of other issues that were discussed earlier, in terms of mental health issues, systemic discrimination issues, stigma issues, as well as substance abuse issues. So these are the intersecting factors, that have to be addressed if we have to address these issues. And superimposed on this is the rising cases of syphilis, which we know there is an outbreak, and the numbers in the prairies are startlingly very, very high. And a lot of these are actually in where we had not seen this before, which is congenital syphilis, which should not be happening in a country like Canada. And infectious syphilis, and these are in women, in indigenous populations, indigenous women. So there is a significant amount of worry. And this year, Public Health Agency showed some numbers, which there's a slight decrease, but we don't know whether this is a consistent trend or just one-off that we are seeing that. So I just want to add that, while the data is the data and the Public Health Agency is doing its work to collect the numbers on this, CAHR is much more focused on the underlying issues in terms of what we can do to address this through research. And as I said, the Indigenous-led research is a priority within the STBBI research initiative for CAHR. In my role as the scientific director for the Institute of Infection and Immunity, my institute, along with the HIV Advisory Committee, SHASRAC, provides guidance on scientific and strategic priorities in the STBBI and HIV research area. So I'm not going to go through the whole list of things that we do, but I just want to draw your attention to a recent announcement of my colleague, Dr. Chelsea Gable, who is now the scientific director of the Institute of Indigenous Peoples' Health. After 2.5 years, we actually have leadership. She's a Red River Métis from Manitoba. So she is leading the initiatives and the overall strategy for Indigenous people's health research within CAHR. And I actually work very closely with Chelsea, not the least because she's also at McMaster, as am I. So we actually meet frequently for coffees and have discussions. And she has worked in the HIV area as well, so she's very familiar. She's part of the FEAST network, as you know. So just to flag that within the Indigenous people's health research, CAHR has one of its largest funding investments, about $105 million over 13 years, which just got renewed, where all institutes participate in that in the NEARS network, the network environment in the Indigenous people's health research. Dr. Gable and Indigenous IIPH actually leads that, and all institutes participate that. I also want to draw your attention to the Indigenous-led research, through community-based and health services programs, where the STBBI initiative has made significant investments, including in AHA Center, FEAST, WANISCA. Many of you are part of those networks. And then in 2023, in response to the growing syphilis epidemic, which SHASRAC and Dr. Falk is sitting here, and he was the SHASRAC chair at that time, we had multiple discussions how this was a growing concern in the Prairie, especially in the Indigenous populations. And in collaboration with Public Health Agency of Canada, we were able to roll out a rapid response funding, which funded 7 teams across Canada, along with some knowledge mobilization specific funding to the tune of about $2.6 million in that year. Those fundings are coming to a draw, so I'm here basically to listen to how the work is going and what are the needs of the community. So I just want to flag that. And then also in terms of our continued engagement through listening to the Indigenous community and programs like the Research Excellence Diversity and Independence Program, or READY program, which is a capacity building program, which came out 2 years ago, where we funded racialized women and Black researchers. And very pleased to announce, and you'll see that coming out very quickly, very soon, that towards the end of the summer this year, there's going to be READY 2.0 that will launch with an additional stream, a separate stream for Indigenous scholars. So the idea here is to build capacity for Indigenous scholars to become faculty members and be able to launch their research programs in collaboration with their communities. So we continue to, do this work. Again, the investments are not to say that, we're doing really well or we've done great things, but it's basically to say that there is a commitment on behalf of CAHR in the reconciliation process. We're listening. We want to know more on how we can do and what we can do. And basically to remove the systemic barriers. I mean, that's a very tall goal, but we are working, and I was just talking earlier today, that one small thing at a time, and hopefully over time and with accumulated action, we can start to make some difference, real difference in people's lives. So today's the opportunity to listen to this dialogue. I'm very interested to hear what the panel, how they reflect on this. And to take back what we hear from this into future actions. Thank you for your attention.
I just want to thank Albert and Dr. Charo for that brilliant, effective national and historic framing that we have. Hopefully we all have a better understanding of what's going on, especially in the prairies. Before I introduce the next panel, I just want to kind of just say that it's nice to hear that there's a rapid response for syphilis, that 7 teams across Canada, but if it's coming to a close, I would just encourage that those 7 teams not come to a close, because we are in an increase, not in a decrease. Thank you. So I just want to move on to structural drivers and syndemic data. We have 2 presenters, Dr. Zulma Ruda. She's going to speak about prairie-specific epidemiology and syndemic factors, and Carrie Lynn Lund will speak about structural drivers from individual and community perspectives.
I want to thank the organizers for having the opportunity to be here today. I do not have any conflict of interest to declare. I'm an associate professor and CAHR researcher in sexually transmitted infections at the University of Manitoba. This is the land acknowledgement where the University of Manitoba is located on Treaty 1 territory. But what I want to reflect is that we are now in 2025, after 40 years since the HIV epidemic started. And here in Canada, there are unacceptable health inequalities and inequities that disproportionately affect Indigenous people. And this is very relevant considering what I'm going to share with you today. I always show the faces of who is behind this research. Today I'm here, but I am just one of a huge team. This is the Altogether for Ideas research team, is people with lived experience. And the elder Margaret Lavallee and Chantal Daniels, the director of Ongomisiwink, they have guided our research since we started with the conception through the entire cycle of every research. And here are all the faces that participate, include researchers, trainees, people with lived experience, and primary healthcare workers, and many other healthcare workers that participate in this research. So I want to acknowledge all of them. It's a huge team that come up together, not only in Manitoba, also in the Prairie provinces. So I'm going to start with the first slide. All our funding, our primary funder is CAHR. All our research is publicly available in open access journals. But I want to point out here how HIV in Canada has decreased over time. However, Saskatchewan and Manitoba consistently report the highest rates of HIV in Canada. Saskatchewan has 2 peaks in 2009 and 2021, and Manitoba is the only province in Canada that consistently has a higher rate, that has an increased rate over time. But what I want to highlight is we represent only 16% of the population. However, between 2021 and 2023, we, the 3 provinces, contributed to 35 to 40% of all new HIV diagnoses in Canada. This is the reason I'm here today, to highlight that the Prairie provinces need a specific approach led by people in the Prairie provinces. We depicted this figure is shocking. This is the World Health Organization regions, and depict Saskatchewan, Manitoba, Canada, and Alberta compared to the World Health Organization regions. As you can see, Saskatchewan and Manitoba rates are above the European regions, regions of America, and many other regions in the world. So When we look at the numbers, Public Health Agency reported, for example, in Manitoba, 19.3 cases per 100,000. Manitoba, the government reported 20 cases per 100,000. But I want to highlight that these numbers do not include immigrants, newcomers, and transfer between provinces. So to give you an example, in Manitoba, between 2018 and 2023, that represented 257 people that were new to the program. So these represent a burden for the healthcare system. Here in this slide, I depicted the epidemiology in Canada, and on the other side is the epidemiology in Manitoba. And what I want to highlight, these depict the latest number in 2023. But what I want to highlight is that we are different. Our epidemiology in Manitoba is 50-50, 50% females, 50% males. While in Canada, the main mode of HIV transmission is gay, bisexual, and men who have sex with men. In Manitoba, represents 14%. Our main mode of HIV transmission is heterosexual sex and people who inject drugs, with those striking numbers, and mostly among women. And the other thing is the difference. Unfortunately, indigenous people are overrepresented. As you can see in Canada, females overall represent 41%, males represent 13%. In Manitoba, females represent 81% and males 68%. This is unacceptable. Many people ask us about gender. We collected data. Our epidemiology is mostly cis men and cis women. We collected, there are cases of transgender women, transgender men, and non-binary people, but our main affected population are cis men and cis women. This slide is just to represent all the challenges that people newly diagnosed in Manitoba face. Houselessness. Many people are diagnosed in prison, which is a wonderful opportunity to be diagnosed and to access care. However, many people face barriers when they are released from prison. So we need to work on transitional housing and other strategies. You see the higher proportion of sexually transmitted and blood-borne infections, the higher proportion of comorbidities that we have, mental health conditions. And I want to highlight the polydrug use. We have a high proportion of people who use not just one, they use stimulants and opioids, but they also, this is one of the main differences in Saskatchewan and Manitoba. The main drug of choice is crystal methamphetamine injected. This is important because we do not have a treatment replacement therapy for this. This one is to highlight the panel A is females, the panel B is males. This is to highlight the intersecting conditions that people in Manitoba are experiencing. So to give an example, 81% of females and 62% of males are experiencing at least one of these three conditions. But I want to give you an example. In red, the circle illustrates that almost 25% of females newly diagnosed in Manitoba are experiencing at the same time houselessness, injection drug use, and mental health conditions. This is the reason we need to have an intersectoral approach and not focus exclusively on HIV. And why is this important? Because when you look at the goals of starting antiretroviral treatment and achieving undetectable viral load, the goals are 95% and 95%. However, we are way behind those goals. And the main challenge is that around 80% of people start treatment, which is 15% below. But our main challenge is that only over 60% of people achieve undetectable viral load, and they face multiple barriers, housing, unstable housing, meth use, injection drug use, and many other conditions. This figure is to illustrate that people are experiencing. This was a research where we conducted interview people living with HIV in Manitoba. And what we learned is that people are experiencing not only barriers associated with HIV, people are experiencing multiple barriers associated with substance use, housing, mental health conditions, and COVID. I wrote some stories. Those are heartbreaking stories because sometimes people get blamed. However, women in the Prairie provinces are experiencing tons of intimate partner violence. So to give you an example, one of the stories is my partner ties me to bed and doesn't allow me to take the HIV meds and attend to appointments. People who are experiencing houselessness get their belongings robbed, so they do not have access to treatment. So these are some of the stories that, unfortunately, people in the prairies are facing. And in our province, in Manitoba and Saskatchewan, women are disproportionately affected. We need a gender and sex approach where we understand women's needs and also men's needs. This was a massive community consultation that we performed for a team grant that we got. This was performed between June and October 2024. We partnered several organizations, and it was led with Aboriginal Health and Wellness Center of Winnipeg, Silent Mission, and other institutions. We implemented 10 different strategies because we wanted to reach the most seldom heard population and the most marginalized population. We were able to listen to over 400 participants. Among them, we have registered 302 documented answers, and 229 were clients and community relatives, 58 staff and healthcare providers, and 15 directors, managers, and public health workers. And their needs are survival. The main need that they had was housing. They need housing. The second need and priority that they wanted was drug use and addiction. The third one was mental health. And only after those, they wanted more support to access healthcare services. So this illustrates how people are facing social and structural issues that impede that they can focus in their health. To finish, this is my last slide. I just want to mention that these Syndemics requires intersectoral approach and transdisciplinary suite of actions where people living with HIV are experiencing high proportion of STBBIs, skin and soft tissue infections, high rates of pneumonia, high rates of tuberculosis and endocarditis associated with injection drug use, which is a life-threatening condition. But we have opportunities now to act. Test for all STBBIs, I didn't show, but we just completed a huge research that shows that the rates of chlamydia, gonorrhea, syphilis, hepatitis C are higher in Manitoba, Saskatchewan, and Alberta compared to Canada. We have opportunities to prevent HIV acquisition, offering PrEP and PEP, offering vaccines recommended for people living with HIV, tests for tuberculosis infection, and definitely offering harm reduction supplies. But we also need to think about multimorbidity, mental health, substance use, chronic diseases, and in this case, we have the opportunity to offer wraparound services, so how we can deploy mental health support, addictions medicine, including opioid replacement therapy, other disciplines that must participate here. And the last one, but I think the most important one, is social and structural determinants of health, where people in our provinces are experiencing houselessness, intimate partner violence, barriers to access care, Monday to Friday between 8 to 9. And we have opportunities to refer people to social worker, offer transitional housing, shelters as opportunities of public health, refer women to domestic violence support services, sexual assault and intimate partner violence programs, and expand and offering extended working hours, ideally at night or in weekends where people can access effectively these services. If we are able to implement at least some of these strategies, we can decrease the incidence and prevalence and mortality. This is a huge team effort. I want to thank all our funders and all our team. Thank you.
She's pointing at me. My name's Carrie Lynn Lund. I get called Carrie more often. I am a Métis, member of Gift Lake Métis settlement in northern Alberta. I'm married to a wonderful partner that allows me to do all this. He supports me and follows me. I need his help in all ways. And I am the mother of 5 beautiful daughters and 4 granddaughters. I turned 70 in January. How is that? You look in the mirror and you go, who is that in the mirror? But it's been a wonderful journey. I've been in this area. This is so cool. Like, there are so many people here. It's like we're having a reunion, never mind a conference. It's wonderful to see all the people I love. And I just want to acknowledge that what I'm about to share actually is just repeating back to many of you the lessons that I've learned from you, and I lift up my hands to you for the wisdom and for the patience and the guidance, and that the words that I speak are my words and my teachings that I've learned, so I can only speak for myself. And I hear all that's been said about Syndemics, and we all know the driving factors and all of that. One day I was walking down the hallway in the University of Alberta Hospital, just outside the infectious disease clinic. And I heard 2 of the clinicians were really having this deep conversation, and the conversation was, sometimes I don't even know why I come into work, because I know that most of the people that I'm going to see today won't come back. And the other one said, well, you know, I guess you can only do the best that you can do. I mean, it's up to them. If they decide not to come in, well, no, that's the way it is. And they caught me on a really good day, and I stopped by and I said, well, excuse me, but if they're not coming back, have you ever asked them why? Do you have any idea why they don't come? You've got 60% of people that are, you know, apparently not following the course of their treatments and staying on treatment. Why? And so they kind of looked at me and I said, well, there are reasons for that. And the reasons, have you any idea? And particularly in the Indigenous community, we're talking about a disproportionate number of Indigenous people that are undiagnosed, never mind diagnosed, that are living with HIV, hepatitis C. I have lived experience with hepatitis C, and I know my own journey. But I said to them, I said, you know, we have a disproportionate number of people that have diabetes that leads to cardiovascular disease, that leads to kidney dialysis, that leads to. We have a disproportionate number of people taking their own lives. In their families, you know, you get over one, I can't believe, but somebody that is on my team, their loved one passed away. They had to wait 16 days to have a wake because all of the facilities in their communities were booked for wakes up until that time. It was back to back to back to back to back. And as a community, you go into grieving, and it's a process, and honoring the life, and you grieve together. And you can't even come up with a breath until there's another one. And so all of a sudden we've got what I call, you know, just this building grief that comes on. And then on top of that, you've got people that are disproportionately arthritis and different variations of arthritis. And so they're taking medicines, and what about those who are not covered that can't afford the pills? And what about those who don't have a band membership and who live off of settlement, or we don't get transportation anyway, but off of the reserve, and they don't have medical transportation there? And what about, where do the kids stay? Because kids aren't allowed to go with you. And you don't know when you go to sleep if you're going to have a meal in the morning, so these are all of the bad things that are happening there. What about those who are so starved for love, for so starved to have a relationship that when their partner says, you're not wearing one of those, he's not wearing one of those, because it reduces the pleasure. Never mind the risk. And you don't want to lose that relationship. So these are all deficit things. Well, I want to stop right there, because we all know this. But it's not news to anybody else. What I want to bring it to is, what about, never mind the intergenerational impact of residential school, what about the intergenerational resilience that has made it possible for a lot of you to be here now, that you're living? The strength base, the wellness. The next time somebody comes into into an office of a clinician, it should be a celebration that they got to that point in their life that they're seeking treatment. And you should be talking to them about, how can I support you? What do you need? Things are so fragmented. Funding is canceled and shortened in the community organizations that get it, that can provide the services in that holistic way. But each of us have a responsibility to be able to look at that individual and not have assumptions, not to say, well, they're not going to show up, or, they're this, they're that. Can we look at that individual as the potential that they can have and support that? I have 6 or 7 different things going on, and my goodness, I can't even get my specialists to talk to each other. And so I don't even understand some of the jargon. I look it up. We have to make language accessible. I had 132 phone calls in the last months from people going, Carrie, I don't even know what they said I had. I don't understand what they want me to do. Can we not just take the jargon that we use in research, in medicine, and make it conceptual and relatable so that people can make informed decisions, and that they can be a partner with you in the treatment, and we can all win in that. Hi.
Thank you to our speakers. They've really introduced the structural drivers and systemic data. I think that the data itself is excruciatingly alarming, and we all should be doing something in our fields, especially if we're in the prairies, to do something about that. I want to thank you for that presentation, and I also want to, as we close this section, I want to name what's been a bit left unsaid, but it's absolutely central for Indigenous peoples living with any STBBIs, and that's the impacts of anti-Indigenous racism within health systems, housing, policy, and beyond, and the deep ongoing effects of colonialism and intergenerational trauma. These are not just social determinants, these are structural violences that shape every health outcome. It's why people aren't coming back to the doctor's office for many of us. For those of us working in HIV or STBBI care, and doing research, I'm going to ask you at the end for the Q&A to think of a question, and I want you to consider, how are you confronting these systemic injustices in your work? How are you working to shift power back to communities? And I invite each of you to sit with this as we move forward into the next discussion, where we actually hear from community. So we have 3 presenters: Levi Foy, who leads 2 spirit-led harm reduction at Sunshine House; Caitlin Roberts, who works with perinatal HIV care and housing first with Sanctum; and Laverne Gervais, who works with Gunny Gunny Chick. And so I'll first invite Levi.
So thank you very much for the introductions, and thank you, Albert, and everyone for framing this conversation. My name is Levi Foy. I'm originally from Couchiching First Nation, which is located on the border of Ontario and Minnesota. And I've been working and living in Winnipeg off and on for most of my adult life, so about 25 years now. I work at a place, I have the privilege and the honor of working at a place called Sunshine House. I am the executive director there, and it's a harm reduction drop-in and resource center. It focuses on inclusion, respect, and safety. And so sometimes when I'm sitting in this room or when people ask me, like, how do we get people engaged in testing and stuff like that, I'm like, I don't know. I actually have no ideas. And I don't know what I was going to say today. And so I'm just going to tell you a story about what it is that we do. And then hopefully you can take something out of it. And I'll try to keep this to my allotted time here. So we're open 7 days a week, 365 days a year. On a busy day, all of our programs are centered around two main drop-in programs that is in a model that we call the Auntie's House. So it just has to feel familiar, should feel kitschy, tacky, should feel like an auntie's house. You never know who's in charge. There's some rules, but you just kind of do whatever you want to do sort of thing. Just don't fuck up other people's shit. And so we do that, and then we also run the province's only formal overdose prevention site. So on a good day, on a busy day, we'll see about 600 people who will come through our doors at the overdose prevention site and at our drop-in center. There's always food, there's coffee, tea, whatever there might be. From there, people can get engaged in more specialized support services, specifically for folks who might not be captured elsewhere within the system in Winnipeg. So we have the Gijawanaman initiatives, which in Anishinaabe language, Gijawanaman means I love you, I see you, I value you, in a deep communal way that we're all supposed to have with one another and with the beings that we live with every day. And that team specifically works with people who are navigating sexual health and well-being, Two-Spirit trans ID support, and they also do refugee support, so newcomer support. Winnipeg being located where it is located is a relatively easy port of entry for many refugee claimants who have to cross the border in the ways they're forced to cross the border because of the Safe Third Party Agreement. Additionally, we have Zagituwad. So Zagituwad is also another Anishinaabe concept of people being able to choose what they love. And we all have that desire to choose. We all have that responsibility to choose what we're going to enter into deep relationship with, and this is specific to housing. We run the only residential facility in Winnipeg for 2S LGBTQIA+ people, specific for those people, and we also have the only housing-specific support team in Winnipeg for 2S LGBTQIA+ people, and none of those things existed at this time last year. So those are all both new programs for us and for the city. We have a typical board. But we also have peer advisory circles that kind of guide every single program that we do. And those peer advisory circles are made up of people who use those programs. And the program directors are responsible to answer to those people, not me as their boss. I handle the HR, finance kind of stuff. It's garbage, and I don't like it. But they get to do all the fun stuff, working with community members and developing programs that are responsive to people's needs. In addition to that, we have over 80 staff, and over half of those folks are people who have used our services before. And that includes 4 of the 6 directors. The Sunshine House model is predicated on we make sure that we have a clear working definition of everything that we do. So harm reduction is not only just the distribution of supplies or that kind of stuff, but it's also ensuring that people have access to all of the tools that we have access to. And it makes sure that they have access to all of the education that we have access to, knowing that we're imperfect and knowing that we're going to probably mess up, but at least you can do that. In addition to that harm reduction, it must also include that element of non-judgmental element. So even if participants are doing things that are incongruent to what we might believe they should be doing, that's not our responsibility to say so. And in such a busy facility, it's really hard to implement things like STBBI testing, HIV prevention, especially once, as Zelma had pointed out, most of the folks that we work with, that's the last of their, when I talk to people about, oh, have you done HIV testing? And they're like, why the hell, I don't have that. That's not on my mind. Of course it's on my mind, but I don't have the time to do that. So we have to be really sure that all of our programs specific to sexual health, STBBI testing and whatnot are recognizing the real lived experiences of individuals. So everyone is welcome to our drop-in programs, and when we do run testing clinics or vaccine clinics or whatever those look like in our drop-in programs, typically we have a lower uptake by the cis-het men who participate in those programs and more response from gender diverse folks and women. I've also seen in our programming that evening and weekend programming is much more successful in getting people to engage with testing and getting people to engage with conversations about their sexual health and well-being. And of course, that's because they don't have those additional stressors, aren't there? They don't have to meet their worker, they don't have to go meet their probation officer, they don't have to go to the next spot to eat, and they don't have to do that because we can kind of capture all those things in that moment. And then we also ensure that conversations about sexual health are just part of our overall, and testing and prevention and treatment are a part of our overall health and well-being. So all of our intake forms and all of our documentation forms are centered in an Indigenous model of focusing on the 4 quadrants of one's being. And so this is also very effective in the stuff that we do. And then particularly for our residential facility, we make sure that when people are doing their intakes, we have our intake process is explicitly sexual. So we'll be like, please don't fuck in our shower, please don't have sex in our hallways, and don't do that. Because the minute that you can be that open and that honest with people coming into your space, then they're gonna also be open and honest about their needs and that kind of stuff. So being really real in that kind of work. And that's really, really been super helpful in really navigating those conversations, as well as and just helping us get people to be engaged in that process. Finally, the sadness, as one of the other speakers had mentioned, that there's been a number of initiatives, but as Indigenous queer people, we're used to kind of initiatives coming and going through our lives, and sometimes they're really useful. And for us, particularly at Sunshine House, one of the 2 biggest things that have been a drawback to our ability to have these conversations is our lack of access to rapid tests, because that limits people's own power to be engaged in their own journey, as well as the clawback of funding or the non-continuation of funding specific to syphilis work in Manitoba. We were one of the organizations that received some project dollars for that, and there's no project dollars going into this fiscal year. We developed a really fantastic peer-led booklet on how to engage in rapid syphilis testing in Winnipeg, and unfortunately, it's just going to sit on our shelves for forever probably. And the next time it rolls out, it'll be like, oh, we'll just try something new again, and that's just kind of how it is. Needless to say, we just continue to do what we always do and just work with whatever we got and try our best in the chaos of the landscape and the chaos of people saying they care about what you do, but not actually putting any resources into that care. So that's us. Thank you.
Hi everyone, my name is Keelan Roberts and I represent Sanctum Care Group, which is an organization based out of Saskatoon, although we do operate programs across Saskatchewan. We primarily focus on patients who have complex health and social issues. Today I'm going to focus on our mom baby programs, and I'm very mindful of time, so I'm going to try and be really quick about it. A hard thing to do, but I will try. So Sanctum 1.5 is our HIV and high-risk pre- and postnatal care home. It launched in 2018. When I was a frontline HIV case manager, I was tasked with working with women who were HIV positive or pregnant and or at risk of contracting HIV while pregnant. And it was a pretty hopeless job. We worked with women who had access to no supports, were actively using, were exposed to violence on a daily basis. And so really we were just putting out fires. And so they'd go into hospital, they'd have their infants would be removed from their care, they'd be re-traumatized by the system, only with the expectation that they were gonna jump through a bunch of hoops for the ministry to gain access to their child that they never actually had an opportunity to bond with. And that's really where 1.5 came into play. We started with the basics. What if we, gave women access to housing, nutrition, and support. And maybe by doing that, we could layer in the interventions necessary to not only prevent the transmission of HIV and other STBBIs, but prevent children from being apprehended at birth. And so 5 years later, 189 mothers and their infants have been served by this program. So we primarily serve women who are pregnant and injecting drugs, or women who are HIV positive and not on medications or engaged in care. We offer a wide range of medical supports, including access to infectious disease physicians, primary care physicians, and we work really closely with pediatricians when the infants come back to our program with their moms as well. Obviously, we require a lot of psychosocial supports for the women that we work with, from social work to a dedicated ministry team that is trauma-informed, trained by our organization, familiar with our policies, which typically aren't standard practice for working with pregnant women in our community. We have a therapy dog named Prairie, and we're just wrapping up 4 years of research, and he has been consistent across the research as he's a 160-pound Newfoundlander, but every woman makes mention of him and the impact that he has had on their feelings of safety and security when in our program. Obviously, 24/7 support and connection to a lot of different services in the community that will continue to support them when they graduate our program. How we offer support, everything that we do is trauma-informed. It's very individualized care, and there's not one kind of case plan that exists that is the same for the women that we work with at 1.5. We do a lot of stabilization. The women that we work with are almost all actively using when they come into our program, and so we employ a lot of harm reduction strategies, do a lot of stabilization. Obviously, most of the women who come into our program want to parent, and so the goal is sobriety. And so prenatally, we do a lot of work with them with addiction support and stabilization. Just quickly, some of the data from our program. So this is all years data. So we primarily work with Indigenous women. As I stated before, almost all of them are actively using, most of them are using crystal meth, and very few of them have access prenatal care at the time of admission. The high-risk indicators for the women who come into our program, sadly, this domestic violence has almost doubled for the women that we serve. So 49% of them are exposed to domestic violence when coming into our program. Almost 80% of them are homeless. So we have pregnant women wandering our streets homeless in Saskatoon and across Saskatchewan. And obviously, none of these women are experiencing any, they're all experiencing more than one of these things at the same time. Despite the multitude of barriers that these women face when they come into our program, they are incredibly successful in maintaining custody of their children when they graduate. We only keep them about 3 months post with their infants, but this is a real testament to what the mother-infant dyad, the bond, can do for a woman who's struggling, for example, with addiction. It is a major motivator for change. And as you can see, we were able to, increase stable housing by 188%. We have no cases of vertical transmission. For prenatal admissions, I just want to make that clear, we still have cases of vertical transmission in our community. And obviously a massive decrease in substance use for the women that we serve, and also a massive increase in prenatal care. Less than 5% of the infants that we work with have gone into the foster care system. As you can see, we measure how many of the mothers have come into our program who are also in the foster care system as children, and that represents almost 60%. And so it's really important for us as an organization to break that cycle. And how do we do that? We do that by keeping moms with their babies. And so even for the mothers who can't parent their children, we work really hard with our moms to identify healthy kin prior to delivery, so that even if mom can't parent, we can connect that baby to healthy family so that it never interfaces with the foster care system. Similarly, our PORT program, it kind of operates like Sanctum 1.5 on an outpatient basis. The goal to work with women who are at risk of having their infants apprehended at birth. We've worked with 448 mothers and their infants since launching in 2021. There was really no dedicated team in the province of Saskatchewan to work with high-risk pregnant women, and that's why PORT came to be. Obviously, there's a narrow window for intervention. You have 9 months to support these women, and so we put forward a proposal to the province to actually have a team dedicated to working with just that. I'm not going to go over referral criteria. What I will say is we provide very intense case management to these women. We coordinate services for them. We do monthly prenatal rounds with infectious disease, with primary care, with obstetricians and gynecologists to ensure that we're kind of covering all areas of care for the women that we serve. And again, really compelling data coming out of these teams. A whopping 31% of them are syphilis positive on admission to our program. Despite that, we have a 100% treatment rate. Despite the fact that close to 80% of them are homeless, almost all of them are actively using. Because of the relationships that our teams build with the women that we serve, we are able to make incredible gains with these women in terms of getting them access to prenatal care, and also access to physicians who are also trauma-informed makes a huge difference. Again, demonstrated that we are very good at increasing stable housing, at increasing access to prenatal care. And again, despite the multitude of barriers that these women are faced with, 80% of them have custody of their children at time of discharge, with only 5% of those infants going into the foster care system. I know I've gone through a lot of data and we're running out of time. I will leave you with two numbers. 6 years is the number of years that we've operated, and 541 is the number of infants we've kept out of the foster care system.
All right. Ani buzu wambadi studio rita bo makwana do dam Treaty 1 do G. My name is Laverne Gervais. I am from Treaty 1 territory. That's the territory that holds the band that are the reserve that I'm a member of, Peguis First Nation, and the city that I was born and raised in, Winnipeg, Manitoba. I'm Anishinaabe, and I'm a second-generation French-Canadian to that territory. And I say miigwech for welcoming and having us here, having me and my team and whatnot here on this in this land and the territory. And I want to acknowledge your ancestors and the ancestors that I come and represent. I also want to take a little second and acknowledge our Two-Spirit and brothers and uncles and mushums who led us in a lot of the work that's happening around HIV and treatment prevention, awareness and education. As an Indigenous woman in our territory, and you saw all the stats of what we're dealing with, then they continue to support and educate us on different ways of dealing with this illness or these viruses. But speaking in 5 minutes or less is a challenge I don't appreciate. My colleagues have done very, very well with. But so I thought what I'm just going to do today, since you've all seen all of these numbers that I live with every day, but I'd rather talk a little bit about just the great, amazing team that I have, that I get to work with, whose real goal, some of them, they don't know some of these figures by heart, and their goal is just to continue to be fucking fabulous as Indigenous people, and to share that message to our relatives with love when they come in and seek us out. So I just thought I'd talk a little bit about our agency. So Gani Ganichik means those who lead, and that's kind of the value system that we go by. And our agency has been in our community for over 20 years, led by Indigenous women, predominantly in Two-Spirit, folks that have also been working together to identify that we needed increasing spaces that are safer for the folks in our community, especially Indigenous women in Two-Spirit, but we need safer spaces and more of them. And so in that case, Gani Ganishik does a lot of work with youth-focused programming, education, and women. One of our other programs right now is Velma's Place or Velma's House, which is a 24/7 drop-in. Even though it's not permanent housing, it's a place where people can go and rest. And there's not many places in our city where you can do that, where you can just sit and not have to worry about what's around you, not worried that you're going to be kicked out of a public area for sitting down. A place where you can just go and maybe do a load of laundry if that's what you're dragging around with you all day, get some food in your stomach, a cup of coffee, and sit and visit. At the Lodge, we've been going now for about 3 years. June's going to be our birthday and our birthday party. And we were brought in, Gani Ganichik has done work in STBBIs for probably since its inception, focused a lot on Indigenous women living with HIV specifically. And women have taught and educated all of us a lot about what that reality is to live with a highly stigmatized virus, but not only a highly stigmatized virus and others, but also as Indigenous women, many who are brown-faced, in a city that is violence on every corner. and what that means and how you're supposed to navigate a healthcare system that treats you no differently. And so some of the work we've been doing and we were looking at, and I just brought slides because I like pictures and it sometimes keeps me on focus. We'll see what happens today. But we worked together as a team and consulted with our community and women living with and the virus and all kinds of healthcare workers, and we created this Manitoba model of STBBI care. And what it looks at is just some of there's the grounding principles, but just some of the domains or areas that we need to consider when we're thinking about developing a space that's safer. And there's more than one or two places. And so we had 8 domains that our community helped us develop to look at of like, these are things you need to think about to evaluate regularly, and get feedback annually on. This is not a one-off. This is a long journey of striving and working towards creating something. If we are gonna undo racism, it's not gonna happen through a one workshop. If we're going to undo the violence, it's going to take a generation of shifting values and beliefs and confronting those values and beliefs. So I won't go through all of them because now 13, but one of them there on the top that I was thinking about when I came here is the issue of accessibility. So I wanted to talk a little bit about our team because a person's coming into any space, that initial visit can make or break their care. If they have the bravery and the courage to step into a place and are greeted by somebody who's just having a bad day, sorry if I mock that a little bit, but that's sometimes the response I'm given, that can make or break not only their experience and their access to care, but their family, their relatives, their friends, because they're not going to refer you back. So it's really critical. And one of the groups we have, and they're brilliant, amazing people, is our aunties. We use a similar kinship system as Sunshine does too. And our aunties are the first to greet and embrace people when they walk into the door. And the first thing they're asking is, do you want a cup of coffee? Need something to drink? Some food? Just have a seat. And eventually find out, explain what we have to offer for folks when they come in. And sometimes people come in and they've come in, carrying all of their luggage and they just want to sit down for half an hour. How they find us always amazes me, but they do find us. And then we have also, let's see if I can pull them up. This is a little bit of our team. Some of our aunties, we do outreach, but we also do drop-in. People can come in, they'll hear the language spoken, and I mean the language of Anishinaabe or Cree sometimes when they walk in, and that does amazing things to your body and your mental health when you walk into a space where you hear the language of your relatives. We work with borrowed staff, nursing staff from the WRHA. Most of them have been Indigenous, but now we do a lot of folks that are non-Indigenous because unfortunately the system doesn't seem to understand how to support our Indigenous staff, our nurses, our physicians to do the work that they were born to do, which is take care of people. And so a lot of people are exiting that system. So if I would make a recommendation is that systems figure out how to care for the Indigenous staff that are working inside there so they can do the work that they were meant to do. And so we have some staff that come to us and we build those relationships with those folks so they not only get to know us, but we have a better idea of who they are because we're not trusting our relatives with just anybody. They are people that we have to understand that they know our expectations and those expectations are based in sex positivity. We are done with being shamed for who we are. We are done with our sexuality being shamed. We are done with our bodies being shamed, poked and prodded. We want people who are not only sex positive, but also harm reduction based. Stop judging. Just stop judging us. We do what we do to get through the day. So we need to ensure we have folks that do that and understand that. And that's not a one-off. That's relationship building and that's trust. And I will tell you, we do not have a lot of nurses that we work with. We have a select group of people that we do work with. This is just some of our advertising and some of the things we offer. See, if you'll see in that picture, I don't know, but we're down a dark, dingy-looking alleyway, and people still find us, and when they do, they come back. I know some other folks that come there and they go, oh, hell no, I'm not going down this, but they do, and once they do and they get greeted and treated with respect, they come back. One of the teams on here, as well, are these folks who I absolutely adore. These are our kukums, our grandmothers. Our grandmothers, they have another name which I haven't learned how to say properly, but it kind of refers to the old women that keep the community together, because they do. And how we work with our kukums is intentional. We have not just one person here to take care of everybody, but a team of kukums that work together to not only to embrace the relatives that come in, but take care of the staff too, because as Indigenous people, a lot of what we're dealing with when we leave our offices is the same thing that our relatives who are walking into our services are also dealing with. So we're very intentional on how we start our work day, greeting each other in the language, recognizing our ancestors, sharing what we need to share in our lives, so that when we open that door, we can achieve the goal that we have, which is to make sure our relatives feel love and respect. They don't need to know all the stats. They need to know love and respect and a place that's safe to go. That's what they need. And these kukums do an amazing and excellent job at doing that, of caring for each other, and they're learners. They're learners. So you'll see them here all having a little giggle because they're holding chocolate genitalia. You know, this is what we do. We have a laugh, and then we learn, and we take care of each other, but also we take care of the folks that come in. So I just wanted to share a little bit about them. We do a lot of other stuff, too. At the Lodge, we've been growing. We now have sexual assault nurse examiners who are on site, a growing program called the Walking with Our Relatives that's looking at and taking care of folks that have had that experience with sexual violence or intimate partner violence. And this is one thing I just want to share a little bit too, and I know I'm way over time, but we can't assume that people were using the same language. And so one of the things we always have staff do is ask the nurses what they do. It's amazing. People assume we all understand what everybody does, but I've been learning even my own about how scope of practices are very limited and part of the barrier. And we have amazing public health nurses that go above and beyond what they're allowed to do to be able to meet people's needs so that they'll come in. Sexual assault nurses, examiners have a much broader scope. We have social workers, but that's kind of a dirty word too in our community, social workers. So what exactly do these people do? And that's what building the relationships is about, really getting to know what is it you do. And research is not that far off. Research has been one of the few areas where we've been able to access HIV programming dollars in a way just so we can get some more monies and resources in for folks to be able to get some additional care. But anyways, that's just a little bit about ourselves. We have one of the other things I just want to acknowledge because it's fresh in my brain. So last week we had an incident. It's a little storytelling, if you will. A beautiful young woman who was experiencing psychosis came in, and she got into our facility, and she was not in a good way. She was having a really hard time, and we're not sure how to take care of her, and there's a lot of questions. She did not like me at first look. I mean, I get it. I have white skin. I know what that means when we've suffered through colonial violence. I represent things that I can't control. But she followed me into the medicine room, and the minute she saw the buffalo robes, her focus and her whole attitude changed. Our tools, our cultural tools, traditional values, and healing methods have brought in so much into that space that we don't really deal with a lot of violence when people come in. They come in and they see people in ribbon skirts, they see people, hear people speaking the language, they see just some beautiful faces that look like their aunties and their kukums, and they sit down and enjoy a cup of coffee and hopefully check in with a nurse. And we've had a lot of people come and bring their relatives along with them. So I just wanted to share that a little bit today. So miigwech.
Thank you so much. I think when I opened, I said at Sunshine House, at Sanctum, and at Gunny people are building care models grounded in dignity and culture, and you've had examples of that today. I want to thank every one of our presenters, the panelists, and most of all, the communities. What we've heard today is not new for Indigenous people. We've always known these truths. We're not just talking about health disparities. We're talking about racism, colonialism, structural violence, intergenerational trauma written into our bodies, our families, and our lands. Let that settle. But I need you to hear me because we're still here. We carry the knowledge older than these systems meant to erase us. We carry the solutions born from the land, from the kinship, from ceremony, and from community. So here's my call to action. If you are working in STBBIs, HIV, any of the diseases, if you are working in healthcare, if you are working in research, your work is not neutral. Every choice either sustains these systems or dismantles them. Every policy, every protocol, every research question, every funding decision, it either reproduces harm or makes space for healing. I invite you, I challenge you to ask yourself, whose leadership am I following? Whose knowledge am I privileging? Whose voices am I making room for? And I leave you with this, hope. Hope is not a feeling. It's a practice. It's a responsibility, and it's an action. Let's leave here, not just inspired, but accountable. Let's leave here ready to walk alongside communities, to return to power, to transform systems, and to make good on the promises we speak in rooms like this. Because our people deserve more than hope. They deserve justice and healing, and nothing less than love. I know we had planned to open the floor for questions from our panelists, but in the interest of time, we'll need to hold those for now, and I encourage you to reflect on the questions you prepared, and perhaps they'll guide your continued learning or spark conversations beyond today. Thank you all.